And now I'm pleased to present our speaker this morning, Dr. Ricardo Cohen, who's really been a pioneer in this field and comes to us from, as I mentioned, Hamburg, Germany at the IFSO conference. And he'll be speaking today on metabolic surgery, what have we done right for a BMI less than 35. Welcome, Ricardo, and take it away.
Hi, Stacy. How are you?
Great, thanks.
It's very good to be here with you all directly from Hamburg IFSO. And I'll start speaking on what we have done so far in treating metabolic syndrome in low BMIs, as Stacy just introduced. What we're gonna cover this morning, it's afternoon here in Hamburg, it's the legacy of bariatric surgery, what we have learned from bariatric surgery and then adopted in our first trials in lower BMIs patients, why we have to cross the border for low BMIs, and where are we now, the results we got so far, and what we need to establish this in our current practice. Well, we learned that first, bariatric surgery is weight loss surgery. And really, it works when we think on the SOS trial regarding weight loss. If we compare the control groups at the first line of this chart with patients operated through restrictive procedures or a gastric bypass, yes, it works as a weight loss procedure. But it is only weight loss. Well, if we can read the details, all of us know this, we can resolve 50% of migraines, pseudotumor cerebri, sleep apnea, GERD, type 2 diabetes, stress urinary incontinence. So I don't think it's only weight loss surgery. So we had a trend to think from bariatric surgery to metabolic surgery. Why we think about this? Because this meta-analysis by Dr. Buchwald, published in 2009 in American Journal of Medicine, showed us that we can stop diabetes, we can, I don't like the word cure, but we can put into remission diabetes varying from 56% to 95% of the patients according to each procedure, the gastric banding, the gastric bypass, and the BPD. But this is the next slide will be a chart of what is metabolic syndrome. Metabolic syndrome is a mix of hypertension, renal failure, obesity, dyslipidemias, atherosclerosis, diabetes, non-alcoholic steatohepatitis. And those are a definition of what is metabolic syndrome. The problem of metabolic syndrome is a disease defined by symptoms, not by cause. It's very, very, very generic to speak on metabolic syndrome. Metabolic syndrome is progressive. You have a lot of medical therapies, diet, weight loss, exercise might be effective, but there's poor patient's compliance. The drugs got limited effect. They may show progress of the disease. They may slow progress of the disease, but medical doctors are doing palliation because there's no definite treatment with good results long term. And there's a question, can an operation on the intestine cure all that or control that? Yes, it can. Our best information comes from the experience with the effects of weight loss surgery or bariatric surgery. Now we call metabolic surgery on type 2 diabetes, for example. Dr. Porris published back in 1995 600 morbidly obese patients. He compared to 150 patients treated with impaired glucose tolerance versus close to 150 patients with established type 2 diabetes. And look at long term, we have around 83% of euglycemia on follow-up of the gastric bypass and close to 100% of glycemic control in the impaired glucose tolerance group. And Phil Schauer showed in his paper of 2003 while he was at the University of Pittsburgh, he could reproduce the same results as Dr. Porris did 10 years earlier. It's a full and durable remission of type 2 diabetes through an operation that just reroutes the food through the GI tract. The same was shown by Dr. Sjöström in his SOS, the classical SOS study, when we compare the darker blue is the control group, and the operated group, it's a mix of different operations. Mason gastroplasty was there, gastric banding was there, and a bypass was there as well. It's a mixed operation followed by 10 years. A look at the difference on remission of diabetes, hypertension, and hyperuricemia following a bariatric or a metabolic procedure. But if we think deeply, or we just reflect about this, is it merely a correction of glucose levels? If you take a look to some studies that show us the effect on long-term mortality when you compare to non-operated controls, look at the columns. There's a gastric bypass and one study of laparoscopic adjusted gastric banding and the SOS trial with long follow-ups that goes from 5 years to close to 14 years. I just saw yesterday Dr. Sjostrom here in Hamburg showing us the 20 years results of the SOS, and they are the same. We still are having improvement of these operations over the control of diabetes and over decreasing mortality rate in those patients. So we have mortality reduction that varies from 30, 40% to close to 90% of overall mortality reduction after a metabolic operation. And Ted Adams from Utah showed us a very impressive number of decrease of 92% of diabetes-related mortality after a Roux-en-Y gastric bypass. If we think on the unadjusted cumulative mortality on the SOS study, we compare the control, the dashed line, versus surgery, the darker line, we have a really control over mortality at 16 years follow-up, and again, Lars showed us yesterday at 21 years of follow-up the same results. So we're really doing something regarding quality and quantity of life of those patients. So it's not just a correction of glucose levels. Gastrointestinal operations reduce the complication and mainly the mortality of type 2 diabetes. What else? What else did we do? What we did here, we can show this paper published in the Archives of Surgery last year that look at the cost of the diabetic medication pre-op. TIF surgeries market there, and there is a decrease in the use of diabetic medications and a cost saving, a huge saving in costs regarding the use of antidiabetic medications. This includes insulin, new versions of incretins, DP4 inhibitors are expensive, and look what we found after a gastric bypass in the diabetic population. What else we did right? When I first presented this in a grand rounds to endocrinologists, well, I was told that we were wrong, we didn't know what we were doing, and I was criticized, and even the diabetologists were not so friendly as they are today. Believe me, things have changed, the mood has changed. But we studied the mechanism. Pioneer studies from Francesco, April Strader, Stephanie Troy with the gluconeogenesis, intestinal gluconeogenesis, Rulu, Ellison, Goldfein. We studied the mechanisms. We have some evidence of a direct anti-diabetic effect not related to weight loss. We find patients that improve their glycemic control weeks or even days after surgery. And we learned with the big clinical trials, the Accord, the Advance, the Veterans, and maybe the STENO trial, that we have, and surgery provides this, a multifactorial approach. We're not targeting only A1C or glucose levels, but hypertension, hyperuricemia, and lipid control. So we learned from them, from the STENO trial, that was the main trial that first mentioned that a multifactorial approach is important, because you might remember that the Accord trial was aborted because of a higher mortality rate when they started the intensive control only focusing on glucose. So we have to think on a multifactorial approach, and surgery does this. What else we did right? Some big data bank like the BOLD showed us that it's a safe operation. Mortality rate is similar to a cholecystectomy, and it's 5 times less or 10 times less than major abdominal or neurosurgical or cardiac operations. And we had a paper published, the surgical community had a paper published last year that there's an adequate cost benefit when we treat diabetes through surgery when we compare to the best medical treatment. So, with so many lessons learned with decreasing mortality, cost saving. We were pushed to new frontiers in metabolic surgery. But when you have your visa, your passport in hands to cross the border of BMI, we have to be prepared for some things. We have to speak a new language that I call contemporary diabetes. And what is this? We have to understand the terminology and the treatment algorithms. If you compare, for example, the algorithm that the ADA published, the Brazilian Society of Diabetes, the European Society for Study of Diabetes, they're different. We have to understand the terminology and what their focus, what their target, and their treatment. We have to understand that there is type 2 diabetes, a unique name, but there are different diseases. There are some diabetics that have LEDA, the autoimmune diabetes. There's MODY. There's different diseases labeled as type 2 diabetes. You have to learn what is C-peptide, what is an incretin, what are the incretins, and what's the purpose of studying incretins, why the endocrinologists fight for introducing liraglutide or exenatide in their algorithm of treatment. And we have to understand that antidiabetic drugs have a role. We cannot operate patients and just throw the drugs away because they would need some time pancreatic beta cell support. So we have to work with them. Once the former vice president of the US, Mr. Al Gore, said, if you want to go quicker, go alone. But if you want to go far, 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 go with a group. You have to have support. In a good amount of patients, surgery is not magic. We have to keep patients with drugs. We have to withdraw insulin very slowly. We have to avoid what is glucotoxicity. Glucose impairs the beta cell secretion of insulin. We have to learn what's lipotoxicity, and we have to learn how to withdraw insulin in the postop. We need to understand with our peers endocrinologists how to titrate insulin. What's the difference of Lantus, of Humalog, of insulin pumps? We have to deal with them. And we need to understand what kills diabetic patients, that is the postprandial dysmetabolism and its cardiovascular implications. So it's not only about sugar. We have to study a lot of diabetes to cross the border to lower BMIs. Because in higher BMIs, it's a matter, most of the patients, they have insulin resistance. Their beta cell still works, and when you reduce the insulin resistance by reducing the abdominal fat, probably most of them will get rid of diabetes. That's different in low BMIs. It's a different disease. But I'm usually asked, why the hell do you want to study those patients with low BMIs? They're sicker, they're worse patients. Why do you need to explore that other part of diabetes, of metabolic surgery?
Cardo.
There's a simple answer for this. Yes.
Hey, it's Stacy here. I'll stop you just before you get
Yes.
to some of your data. If I can get a few comments from some folks in our audience, if I may. So you've presented some
Sure.
really outstanding data that those of us in the field are quite familiar with. Let's go to Duke University, if there's somebody there who can perhaps comment on, this data seems so self-evident to us that are familiar with it and do bariatric surgery. What kind of data, before Ricardo really gets into some of his research, what kind of data are we going to need to convince people or to be able to offer this surgery to a wider group of patients?
Hi, this is Chan Park. I'm one of the MIS fellows. We don't have any attendings here at present time, but I think that certainly a higher level of evidence is certainly necessary to better support what it is that we do. I mean, it's kind of a difficult question to answer, I guess, in terms of what kind of level of data. I mean, the best level of data that we have out there in terms of randomized controlled trials, I don't think that we don't actually have that data quite yet. I know that Dr. Schauer and your group out at the Cleveland Clinic, you're working to collect some of that data as we speak. Yeah, I think that's kind of where we stand as of today.
Great, thanks for that comment. Let's see if anybody's at Virginia Commonwealth that can maybe add some perspective.
Oh, hi. Jim Maher and Silas Chikunguo. Yeah, I think it's difficult in this country to get experience with BMIs less than 35 because the insurance companies pretty much cut off any funding for that group and don't really like paying for the 35s to 40. We just recently did a long-term review of our diabetic resolution that was published a couple years ago at ASBS. And it's very good. It's not quite as good as it is a year after surgery, but still, at 5 years after surgery, for the people that were non-insulin dependent to start with, it was about 70%. The insulin-dependent ones, there was more sort of recidivism, and it tended to correlate with weight regain, and so the weight, I think, is still important. They've always got the gastric bypass, but sometimes they've got the weight back on. So, I think it's an interesting subject, and we're all looking to see what's going to happen with people with BMIs less than 35. But, unfortunately, it looks like it's going to come from other places than the United States.
Great. Well, thanks for those comments, Jim. Ricardo, I'll let you pick up where you were leaving off there, and we'll continue with the presentation.
Okay. Great. And I was thinking, why do we need to explore BMIs below 35? Because at least 50% of all diabetics in the world have BMIs below 35. So look at this bar graph. The mean BMI of diabetics in the States is 31.6. In Asia Pacific, it's 26. In Latin America, in Brazil mainly, it's 28. So we have to explore them. We have to treat patients that are at least 50% of the diabetics in the world. And speaking about BMI, why? The BMI has a discrimination. It segregates patients regarding race, regarding its gender, age, fitness status, body fat distribution, and mainly it fails to define the severity of the comorbidities. Those are, they are BMI 40. Are they morbidly obese? This is a BMI of 31. She got diabetes, A1C 8.8, used 3 drugs, insulin, hyperlipidemia. Who needs or deserves to be operated? That 40 BMI or this one was 31? The concept of malignant obesity must be within us. BMI should not be the only criteria. I'm not bashing the BMI and throwing it away, but we need other criteria because, as I mentioned, it doesn't predict the cardiovascular risk. There's no BMI cutoff that tells us if surgery will be effective or not. BMI is not adequate of predicting diabetes control, and it doesn't predict mortality or diabetes-related morbidity, so it should not be the only criteria. And there's a very nice paper published in 2009 by the cardiologists that there's the obesity paradox. The lower the BMI, the greater the cardiovascular risk and mortality for diabetes. So we have to think. Those are the surgeons in the world who just crossed the border. Dixon, Paul Bryan, Wei J. Lee from Taiwan, myself, and Cellini from Europe, studying gastric banding, gastric bypass, and BPD in BMIs below 35. I'm going to start exploring quickly our experience. This is our first 666 patients. This was submitted to JAMA. It's under review. I hope they accept because it's attached to the IDF statement that was just published, issued on March in New York, and we submitted and just reviewing our data. This is the first gastric bypass, 30 to 35, with more than 5 years of follow-up. We have 72 months of follow-up here. So we studied 66 patients. We follow everybody so far. The BMI is here. It was confirmed diabetes, and we excluded autoimmune diabetes with the antibodies. Diabetes was severe, mean duration of 13 years. 40% of the patients were on insulin, and A1C was 9.7 at start. This is a very, very interesting outcome. We have 88% of remission. We define remission A1C below 6.5 without medication. We have 11% of the patients with less medication than baseline with A1C below 6.5, and we had one non-responder. This is the chart of A1C control over time, with the standard errors. Very nice control of A1C over 72 months. of rapid and durable improvement of fasting glucose. And after a meal challenge from baseline to 6 years, we have a better secretion of C-peptide. We have a stimulated C-peptide better with significance 6 years later than baseline. So it's an indirect evidence that we're improving beta cell function. There's a nice decrease in systolic and diastolic blood pressure. There's no significance in the decrease, although the graph shows a decrease. There's no significant statistical in systolic, but yes, in the diastolic blood pressure. Control of total cholesterol, triglycerides, control of total cholesterol, triglycerides, and LDL. There is an increase of HDL, but without any statistical significance. And what was interesting, and maybe call attention to the editors of the JAMA, that we plotted our data in the UK PDS risk engine at 10 years. This is a prediction, math model prediction of cardiovascular risk. And we have a significant decrease on coronary artery disease, baseline to 6 years, fatal coronary heart disease, stroke, and fatal stroke. So we can, it's implicit that it's not a randomized, it's a prospective study, but plotting our data in this cardiovascular risk engine of the UK PDS, we show that we can alter the course of life of the patients with diabetes. In this small cohort, it was 66 patients with no mortality, no risk, no leaks, no reoperations, and close to 45% of minor complications. And what about even lower BMIs? In lower BMIs, we did the duodenal bypass. And those are the two forms that we did, the two protocols. The first with the stomach intact and lower and shorter limbs, 50 centimeters of the bilipancreatic and 100 in the sleeve DJB. What we call the sleeve DJB is a short switch. If you see the picture on the right side of your screen, it's a sleeve gastrectomy with it's a short duodenal switch, but without any restriction. We do this over a 60 French bougie. And we tested exactly comparing patients with a DJB without marked weight loss, and we compared to a normal glucose tolerant group. So we compared DJB versus normal glucose tolerance group and see what happens regarding the beta cell function. The mean BMI in this cohort, we did 35 patients. We compared to 35 normal glucose tolerant patients. The mean pre-op BMI was not high, it was 27.8. Weight loss was modest, around 7% at 3 months, but most of them returned to baseline at 12 months. And it's important to highlight that 5 of them gained weight versus the baseline. We had 20% of all patients with A1C below 6.5 at 1 year without medication, 40% of them with A1C below 7. We consider remission with below 6.5 and below 7, although within the normal range, we consider this partial remission. And we had a significant decrease in medication score at 6 and 12 months. What's more important, through MET models, this was studied in collaboration with Sam Klein from WashU. We studied through MET models, the C-peptide secretory response, the insulinogenic index at late and early, and the insulinogenic index compared to the insulin resistance. There are complex MET models, and we could show an improvement of beta cell function and all indices of responsiveness to glucose ingestion that increased 2 to 3-fold after the DJB when we compared to baseline. We could show that this glycemic control was not related to weight loss. Although it doesn't normalize the beta cell function, it has a significant effect over it. So it was a very important, it will be published soon in Obesity, not Obesity Surgery, Obesity, the medical journal. And it's a good clue that we can do something over the beta cell function.
Ricardo, may I interject?
Sure.
You showed some really outstanding data, and I'd like to get a few comments on that. If we could go to Indiana University first. Now, there's some small randomized trials looking at the band in lower BMI patients from Dixon O'Brien's group. Sam, are there today? Everybody's probably in Hamburg today, I'm guessing. Let's try maybe Carolinas Medical Center. Back to my question. The basic question is, what procedures should we be offering in this BMI group. There's some randomized data looking at the band that also shows significant improvement in metabolic syndrome, diabetes. Ricardo has presented some outstanding data on a bypass procedure that we think has probably a more powerful effect. So what's the risk-benefit analysis going to look like in this lower BMI group?
Yeah, thank you for coming to our center. We have several of our bariatric surgeons here. I'd like to call on maybe Demetrius Stefanidis first to give his opinion.
Can you hear me okay?
Yes.
Can you hear me?
Yeah.
Okay. So thank you to Dr. Cohen who did an excellent study and present some really good data. I think that from what we've seen so far, clearly the bypass has a better effect on diabetes, and in appropriate hands, the morbidity and mortality of the procedure can be minimized, especially in this smaller population where I personally believe the risks are really small, and just because the procedure is a lot easier to do. We also know from literature that patients who have a lower BMI generally tend to lose a higher percentage of excess body weight long term compared to the really high BMIs after the bypass. So something that's also compatible with Dr. Cohen's data, that means that long term they're likely probably to have more weight loss, and if that indeed is associated with also with glycemic control, they may have a lot better outcomes. Our experience with the band in our institution has not been very encouraging, independent of the BMI. So we tend to favor, I personally would tend to favor the option of the bypass, especially if it can be done expertly and with a very low morbidity.
Great, that's some great insight. And I'd like to go to another side to ask sort of a follow-up question on this. Maybe back to Jim, if you're still online at VCU.
Yeah.
So you know, there's been a couple small and multi-center trials looking at endoscopic therapy for bariatric patients and weight loss. What do you think? Can you predict the future of endoscopic therapy, and should this be, in terms of a risk-benefit analysis, something that we really should be more aggressive within the lower BMI patients in pursuing?
Well, I presume you're talking about some of the things, the newer things being done, and the endoscopic sleeves and that sort of thing. Is that what you're talking about?
Yeah, the sleeves, and then
I mean that. Go ahead.
Oh yeah, what comes to mind are no one's hit a home run yet with any of these endoscopic plications, but the TRIM trial, the TOGA trial, things that have been initially tried that still have, I think, potential, but just need to, I think, continue work.
Well, I think, I don't know who said it, but I've heard it all my career. Every bariatric procedure looks good for 2 years. We've got the Ohio State gastroplasty, the Gomez gastroplasty, all of these things were done in the 70s and 80s, and they all look pretty good for a couple of years, and now we all see those people coming back for actually effective operations like a gastric bypass. And so, I think these things with the low BMI patients and the diabetics looks very encouraging, but once again, I think we need to see 5-year results, and all of these endoscopic procedures, maybe with the exception of the endoscopic bypass, really repeat many of the mistakes surgeons made in the 70s and early 80s. I think we've got to, follow the principles. You have to have a small pouch up above. You have to have outlet reinforcement. When those things go by the wayside, I have real doubts about the long-term efficacy. I mean, the sleeve gastrectomy, you know, everybody likes the sleeve, and maybe it's going to make a difference, you know, taking the ghrelin secreting section of the stomach out, but, you know, boy, the sleeve gastrectomy looks to me disturbingly like a VBG that somebody forgot to put a band on the outlet. So I've got real long-term doubts about all of these. I think it's like any sort of laparoscopic surgery. You've got to do it laparoscopically the way you did it open if you hope to repeat good results.
So it sounds to me like
I hate to be a naysayer, but
if you were able to operate on 30 to 35 diabetics, your procedure of choice would continue to be a gastric bypass?
Yeah, at least, you know, until somebody shows me that something else is better. I think all of these things with short sleeves and all of that are fascinating. And, you know, that brings up the other problem that we have in this country with human research, which is, you know, the legal system. You know, I mean, I just don't think there's any good human research done in this country anymore in the surgical field, and it's for a very simple reason.
Great. Let's continue.
I hate to be so relentlessly negative, but
that's all right. Thanks for those comments, and we're going to go back to Ricardo, and I'll let you finish up your presentation here.
Okay, so what I presented regarding the gastric bypass is 30-35 IRB under an IRB control. It's 6 years follow-up, so I think we are on a right path. The two studies, the first that I showed is the classic DJB with the intact stomach. It's really another trial. It's another trial. And this is the third trial, and just an information, we just finished our endobarrier, the endoscopic sleeve trial with 25 patients at our institution, just started explanting some, and the results, the mean BMI was below 30, it's 29, like our studies, 28 point something. The results of the endoscopic sleeve, they're not as good as surgery. So I don't think there's no magic so far, and I believe that the VCU colleague is right. The gastric bypass has better evidence of better outcomes in diabetes, even long term. 6 years I consider it long term, and I think we have good studies. Well, this first protocol, the DJB with the intact stomach, I have 5 years follow up, and I converted some of them into this form, the sleeve DJB, and the improved diabetes. So the intact stomach DJB, it was a good model of studying the effects over diabetes control without weight loss. We proved a concept, but it's not for every day. It's not ready for prime time. Not even this one. We're just comparing this one now. I'm going to show you with the gastric bypass. And so far, the gastric bypass is better than this one, even if with the pylorus that would control the emptying of the stomach to the bowel, that in theory would be important for glycemic control, and it's not that important as we thought. So let's go on. This is the second protocol. We added a sleeve gastrectomy to the duodenal bypass. It's a non-restrictive, over a 60 French bougie. Sometimes it was very tough to pass this bougie. I won't discuss why we did this. And this is the results at 18 months so far. We did 100 patients. This is the first 50 patients. We ended the trial a year ago. This is the first 50 patients with 18 months of follow-up. Look at the mean pre-op BMI. It's low. It's around 29. This is the total body excess weight loss, 7%. And the results are a little bit better than the DJB. While we had 40% of patients under 7 of A1C in the previous study, now we have 68%, 34 patients out of 50 with resolution, no medication, A1C below 7. There is no malabsorptive component. We have 100% of non-significant fecal fat detection. The next is a very nice chart of the decrease of A1C over time in 18 months. The same happens with the fasting plasma glucose. The same happens with the postprandial glycemia that decreases from close to 300 to 157 under normal ranges after the sleeve DJB or the short duodenal switch. We measured the hormones. I won't discuss this. It's a huge amount of data, but some clinical outcomes. significant decrease in the carotidial intimate thickness. It's a clue that probably it refrains the progression of atherosclerosis, a significant decrease in the systolic and diastolic blood pressure, and a significant decrease in LDL and triglycerides. I think it's still experimental, of course. It seems to be effective. We have some clues that there's resolution or improvement of diabetes without a direct relation of weight loss. Remember, weight loss was around 7%, and most of the patients regain weight after 12 months. There's a low complication, major complication rate around 1.5%, and it's a known operation, and it's a short duodenal switch, so I think it has to be tested. We're doing a randomized control trial comparing the gastric bypass versus this operation, and I must confess to you that the gastric bypass is still the champion. Some studies were done. The first one was reported by Giuseppe Noia in 1999. It's diabetes is not well defined, but he says that diabetes in the first 10 cases, he had controlled diabetes. He doesn't mention the A1C, just the fasting plasma glucose. 2 studies down in Brazil were conducted with what I did first, the classic duodenal bypass with good results, with control of diabetes, with around 40 to 50% of those patients, with 2 years of follow-up in both papers. In Japan, a group just did the same that I did, the sleeve DJB, laparoscopic sleeve gastrectomy with duodenal bypass. I know patients are different ethnic characteristics, genetic characteristics, but they have 100% between remission and improvement within 2 years of follow-up. And we have to think if I'm not a defendant of the sleeve gastrectomy for diabetes for several reasons. And is the duodenal exclusion per se anti-diabetic? We did a collaboration study it's published this issue of SWORD when it compares sleeve gastrectomy versus gastric bypass at the same weight loss. We did with a group from Malaga, Spain. We did the gastric bypass, they did the sleeve gastrectomy, and we compared this that at the same weight loss we had a rapid control of diabetes and insulin sensitivity indices with the gastric bypass, excluding the duodenum versus the sleeve. So bypassing the duodenum, it's more effective than a simple sleeve gastrectomy in diabetes control. Are we repairing an underlying pathophysiology, sick duodenum diabetes? We really don't know. This is the Francesco Rubino's theory. I don't know if he's correct or not. But what we know that it's not, this is a summary of the hormonal changes in both studies. We have really a total and active postprandial GLP-1 marginally significant. It's equal 0.05. It's marginally significant. So it's not that important as we ever thought. And yesterday we were discussing in our metabolic course here on Tuesday in Germany, and it's the same thought of all researchers. GLP-1 is not the major key player in this thing. GIP, PYY, and glucagon. It's paradoxical, but glucagon goes significantly high after a duodenal bypass with or without sleeve gastrectomies. It's interesting. Please pay attention. This is a mix of both results, very summarized for the sake of time, but the results are pretty much the same in the 2 operations. So it's not only GLP-1, it's not only hormones, just something with glucose transportation, glucose absorption, a decrease of insulin resistance because there's a major uptake of peripheral glucose by the muscle. We still really don't know what's the mechanism underlying the resolution of diabetes. We need mechanistic studies. We're doing a CLAMP study in collaboration with Sam Klein down in the University of São Paulo in Brazil. But I would like to highlight a thing, that crossing the border of BMI doesn't mean that all BMI should be operated independently of their primary BMI. We need randomized control trials. And those randomized control trials are on the way. This is a very messy and busy slide, but Stacy's Unfilled Stampede trial is there. There's a lot of trials. Ours is the last one. We're comparing randomized control trial comparing best medical treatment with surgical options, and they are on their way worldwide. But we need to prove what in those randomized control trials. We know that surgery is safe and effective. It's based on the legacy of knowledge of bariatric surgery. We need to know the timing for indication. The sooner the better, or when they are not reversible anymore with the medical treatment. What are the best candidates? The low BMIs, the high, we still don't know. Could be surgery a primary alternative in selected cases? These should be the answers of the randomized control trials. We have patients that don't respond to surgery regardless of BMI. This patient is a woman, she was a doctor, she's a doctor, A1C pre of 8.7, 18 months later 8.5, close to baseline. So there are non-responders in low BMIs and high BMIs. And this is what I think the next chart will tell us. What I think that there are patients, regardless of BMI, the higher the BMI is, the more responsive to surgery they are. There's a thing behind this. We have to find out who are the best candidates for surgery through those randomized controlled trials. We don't have to prove anymore they're effective, because they are. What's our goal? This slide that I'm going to show you, this is the last 3 slides. When I presented this 2 years ago the first time, we wanted to be an arrow in the algorithm of the treatment of diabetes. This is a mix of the ADA and the AACE algorithm for the treatment. Lots of no's, yes, arrows here and there. We wanted metabolic surgery as an arrow, as an alternative to treatment. Our wishes came to real life. On March, the IDF, International Diabetes Federation, they issued a position statement. And they state clearly there that surgery should be considered as an alternative treatment in patients from 30 to 35 when diabetes cannot be adequately controlled by the best medical treatment available, mainly when there are other major cardiovascular risks involved, high triglycerides, sleep apnea, and the list. I encourage you to read this statement because it's very, very important for all the surgical community. So this is our dream came true. They put surgery, bariatric surgery or metabolic surgery, as a first line of treatment with the first steps of medications, metformin and SUs. They consider surgery when metformin and SUs fail in patients with BMI over 35 or over 40. That should be prioritized. And if patients fail of metformin plus SUs, and they fail with insulin, glitazone, DPP-4 inhibitors, incretins, whatever you want, surgery should be considered in eligible patients with BMI from 30 to 35. If those patients keep their A1C 7.5 more than 12 months, despite of behavioral modifications and the best medical treatment available. So I think I encourage you all to read this position statement, because surgery for BMIs from 30 to 35, although BMIs have nothing to replace so far, but we have to think that surgery should be considered in those patients that fail with the best medical treatment available. And the randomized control trials should prove that we can use surgery as a primary alternative in very selective patients, maybe 1 or 2% of them, not operating all. And we should think on doing surgery, the sooner the better, probably. This was proposed by Dr. Sjostrom yesterday, the father of the SOS trial, that we should invest on education of the surgical community and the medical community when surgery should be applied in the randomized control trials. Thank you very much.
Great. Well, thank you, Ricardo. That was really just an outstanding presentation of the field and the lower BMI potential effects of some of these operations, and then certainly your data is outstanding.